I think it's 9:40 and we have everybody here. Welcome. Buenos días, buenas tardes, buenas noches. My name is Alexis Barr. I'm from Transforming Faces, and I've been I'll be your host. Sorry, I just got a pop-up here. Okay, so I'm going to start sharing my screen. And I think we're all set. Can you see my presentation?
Now we do.
I'm doing this. Give me just a second. Okay, awesome. So you're welcome to SG2. This is our topic today, Multidisciplinary CCC Team Building. Okay. Just waiting for my slide here. Okay, so I wanted to remind everybody that we have simultaneous interpretation, and I would advise everyone to set up the interpretation and choose either Spanish or English so you can hear if there were to be a comment or a question in Spanish later on in English. Y les recuerdo a todos los participantes hispanoparlantes que pueden elegir la función de español si le dan interpretación y hacen clic en español. Este es nuestro equipo. This is our team. Sorry, it's our solutions SG2 co-chairs. We had Dr. Emily Gallagher and also Dr. Solomon O'Meary and myself, who's been the host. On our team was made of people from all these countries, India, Spain, Tanzania, Chile, Ghana, USA, Costa Rica, Iraq, Sri Lanka, and also we had different disciplines represented: surgery, we had speech therapies, ENT, pediatrician, and an orthodontist. And this is our entire participants from SG2. And now I'm going to hand it over to Carolina, who's going to take us about, with the introduction.
Thank you, Alexis. Well, related to backgrounds, making the case of multidisciplinary CCC team buildings. What do we mean by multidisciplinary CCC team buildings? Why is this topic of interest to LMIC CCC teams? Research focus: what practices are more effective in building and maintaining strong CCC teams? Next, please. Well, related to what do we mean by multidisciplinary CCC team buildings? Diverse experts unifying goals, bringing together surgeons, dentists, speech therapists, and more specialists. Collaboratory planning and treatment, ensuring seamless, coordinated care to patients and their families too. Enhance patients' outcomes, optimizing results through sharing knowledge and expertise. Teamwork and communication, building strong bonds for a long-term patient support. Next, please. Why is multidisciplinary CCC team building of interest to LMIC's teams? Well, optimizing care, ensuring an holistic and coordinating approach. Maximize resource, reduce redundancy and improve efficiency. Enhance patient-centered care. Address medical, functional, and psychosocial needs. Strain healthcare systems. Build skills and teamwork, and improve communication that reduce treatment delays and enhance continuity. Next, please. Well, related to methodology, we have the foundation resources studies, then we had all these meetings when we discuss with the group. Thank you. And then we have several articles and we check for literature. When we have all this information together, we had our 4SG discussion with all the members and we set the survey that was sent to different specialties. And then after we got all the information, we reviewed the survey and developed the recommendations that we're going to be sharing today with all of you. Okay. So Alexis, can you go backwards, please? Thank you. Related to the survey responses, we have 113 responses from all over the country. And we have 25 of these respondents from LMICs, another from 34 countries, and there were very different areas of responses. We have 31 speech, 26 surgeons, and 13 orthodontics. From all of the responses, we have at least 55% that have less than 10 years working in a CCC team group, and the 79% that were currently in a CCC team group. So I will let you next with Nico, who's gonna be explaining all the different responses.
Thank you, Carolina. So basically, with the survey and like the preliminary work we did, we could understand that there were some concepts and some comments or some ideas on how to get started in regards of developing comprehensive cleft care teams. We also received very relevant information about the team leadership. It was very important for the people participating, the topic of leadership, to move ahead as a team and to provide care as a team. Also, a main topic during the summary was the communication within team members and with the patients and families. It was very important to provide efficient and effective cleft care. Another topic that became very important was identifying barriers. So as a team, identifying barriers was relevant to overcome those and design strategies to overcome those. And also there was another topic about sustainability long term, like how to make this team to overcome challenges and provide care in a sustainable way. Next, please. So we had some comments. For example, in some questions, the three most important initial steps to take while building a comprehensive cleft care team for most people, or more than 2/3 of the people, they were sharing with us that secure funds, financial resources for training and also for sustainability, identification of staffing, HR professionals. And the other one is like a main concern was the space where the healthcare was going to be provided. When asking the top 5 most crucial disciplines to get started with a comprehensive cleft care team, it was very interesting to see that most of the participants found that speech therapists and pathologists were the most important ones, followed by surgeons, anesthesiologists, orthodontists, and psychologists. Next, please. When asking about the first 5 factors considered as extremely important with developing or creating a comprehensive cleft care team, the most people were outlining the importance of identifying professionals that they were qualified providers. The second one was to secure secure financial resources to sustain and establish the team. Another topic, important topic or point to outline was the identification and development of a team leader. Another important one was the availability of an adequate space and infrastructure to provide care. And finally, the availability in terms of time and time of the team members, that those team members, the professionals were available. When we're talking about the barriers, it was important that some of the most important barriers were identified as the barriers in communication. Barriers in regards of communication, it was emphasized the lack of medical records, for example, and also the difficulties to retain the staff at the comprehensive cleft care team. Next, please. So we asked in an open question, there were open questions about the identifications of barriers. Important or like repeated topics we observed was the fact that some people, some of the professionals, they were volunteers and they could be not as stable as ideally for the provision of care. Another barrier was the lack of a common space to be working as a team, so the communication was affected. Another important topic was the lack of adequate or like or the fact that there were improvable leadership roles, and the lack of electronic medical records to coordinate and facilitate communication between team members. Next, please. So when coming to putting everything together and develop like the actions and recommendations, the first one was based, is a broad one talking about planning and strategy. So when creating a comprehensive cleft care team, it is important to plan and strategize to warrant both sustainability and effective service delivery. So we try to like conceptualize this planning about creating a comprehensive cleft care team with some outlines. The first one, compliance with the local healthcare regulations. It's important to understand what is the policy in terms of healthcare to set up a comprehensive cleft care team that is functional. Second is to establish a secure and adequate functional space to provide care. Third, to equip the facilities with the infrastructure and supplies that they are needed to provide adequate care. Then the staffing, human resources, meaning that it was very important to plan and strategize the recruiting, the training, and means for retaining that staff that is being trained. And finally, it was emphasized that it was very important to build strong partnerships with the community healthcare workers to improve accessibility and ensure continuity of care in terms of like providing bridges to the community with the comprehensive cleft care team. Do I continue here, Alexis? Yes. So comments about the before. Yeah, thank you. Some important or relevant comments about creating a new team was to look or foster partnership and collaboration with a local healthcare environment and local hospital. One key on another thing to outline was collaboration, respect, trust, and good communication between team members. Another point to outline was to develop protocols and manuals of operations to make more effective the delivery of the service and ensuring equity and quality of care. Establishing a teamwork dynamic and a referral system that goes also into communication and development of protocols. Coordinating with government institutions, which goes again with the concept of engaging with the local healthcare regulations. Retributions, remunerations for the staff, meaning that it should be looked or should be fostered the retribution and avoiding the volunteers because it provides more stability and commitment of the team, and identification of and establishing like relationships with stakeholders that could support the development and also the sustainability of care. There were different items within the surveys, and again, what were the most important initial steps when establishing? Again, we spoke about that. The financial topic, it was very repetitive, like it was important to the creation of a comprehensive care team to identify and foster financial resources. Also the administration and management support, because the medical and the professionals might not be very proficient in the management and administration side. Securing time, sometimes the providers are not from the comprehensive healthcare team, but from the hospital, so securing availability of time. And also like securing a strategy, budget, and resources to engage with the community, it was also important. Next, please. So, do I continue here, Alexis? No.
Okay.
Who's next?
Great to meet you. Thank you very much. I'm Dr. Hassan, an orthodontist from Iraq. I want to explain my deep thanks to all the attendees who participate here with us, and my deep thanks to Professor Osama Hamdan, President and co-founder of Global Small Foundation, who provide he gave me the rights to use some of the image in his website. The recommendations, number 2, it was leadership moving ahead together. The leadership skills should include how you get to the resource management and how you get to the program planning and team dynamics. And the major points, it's advocacy and community engagement. So that the clinical discipline of comprehensive care team leader, it does not matter really, but an effective leader should have skills to lead in that non-clinical areas, which is the above. Next, please. Next slide. That's to say how you manage the resource management and need skills, and the program planning and the advocacy for all the matters for which dealing with the cleft, and how he deal with team dynamics, because he must be the dynamo for the team. And the important things is the community engagement, because the community engagement is through all the researchers and all the NGOs which work with the subject of cleft. They insist on the effective community engagement. Next, please. Recommendation number 3 is effective multidisciplinary team care is built on open communication, where every provider perspective is valued equally. And that's the communication is further strengthened by having structured approach to address both clinical operations and patient care. Next, we'll continue that. This is for me, Alexis. This is for me or
Nico. Nico can
Nico,
continue.
Okay.
So when looking at the survey questions, for example, how effectively does your team function? Because we had the participants from different contexts of comprehensive care team. Some people were outlining that regular meetings made easy, like the provision of care. That again, outlining that the communication was very important to develop like protocols or like standardization of communication was important, that having like organizational culture to share with all team members the goals and the goals for the whole project itself, and to create this organizational culture with a good leadership where everyone has a voice. That was important for many people. Next one, please. So talking about recommendation number 4, talking about barriers, something that came up from the surveys, and it was very much outlined, was identifying barriers. Barriers are different in different contexts and different for different comprehensive cleft care team, but these should be identified as a strategy. Multidisciplinary team care in low and middle income countries should be addressing their priorities according to those barriers. And talking about those key priorities, again, the concept of having an adequate clinical space to provide care was important. The other thing is like working together, the space and time to discuss patients as a team. Again, one of the main barriers and also opportunities and priorities for most of the teams was identifying a team leader, and identifying a good team leader with good skills, or providing training to get those skills, and offering support for providers to foster retention. So there were many of the surveys and comments where there was challenges about retaining the providers and how to develop strategies to retain those, either like identifying potential strategies to retain those talent. Talking about those barriers, this sort of questionnaire identified for the most important barrier was talking about space, the lack of adequate leadership or to improve leadership, the availability of space to discuss cases and clinical challenges of patients, again, retention of staffing, the importance or the barriers in regards of hospital administration, electronic medical records to have them available to improve communication and to improve data management. Those were the main barriers identified. So yeah, recommendation is identify, and the action would be like develop strategies to overcome those specific
This is for
challenges.
Isan.
Okay, thank you very much. Recommendation number 5, which is the essential resources for sustainability. Some resources are essential for achieving team sustainability and should be prioritized by comprehensive cleft teams, which is the first, for example, this is the number D, but it's called community involvement or support. And the financial partnership, he must be capable for doing all that partnership. And the cost-effective solutions, one of the cost-effective solutions is providing training and its outcome, and providing also the adequate equipment. Some NGOs bring the adequate equipment with them, or providing the essential equipment which is necessary for the work. Next, please. Next. From the respondent quotations, there were points which give strength for the team. One of it's the user of electronic medical records, which will improve treatment planning and synchronization. And another one is the regular space for meeting, which give regular training opportunities. And about the communications, it's important because referrals between team specialists is very important, prioritizing which area is most important in care when starting the patient's treatment, and then holding periodic meetings between team members to evaluate cases. And the regular cleft outpatient department clinics twice a week are managed collectively by surgeon and speech and language pathologist. And also, in addition, there is a joint surgeon orthodontic clinic is conducted twice a month. Next, please. We'll continue that. Thank you very
Now,
much.
Emily will guide us through the discussion. Thank you, Dr. Nico and Dr. Isan.
Yes, thank you both, and thank you, Carolina, for laying out the introduction for all of us. So our team really enjoyed discussing the survey results and putting these recommendations together, but we'd really love to hear from all of you. We want to know if you have any questions about these, if any of these really resonated strongly with you. There's a lot of discussion in the chat I see about our recommendation for having some common space to have communication with your team. And so yes, we'd like to hear from anyone who wants to contribute, if you'd like to raise your hand or chime in. So I'm going to throw one question out for the team to discuss. When in an ideal situation, our team just in discussing our recommendations said that it's great if you have a team room or some shared space where you can get to know the other members of your team when you're thinking about sustainability for your team and cohesiveness. This allows, as we were mentioning, this allows to your team to discuss patient care, but also any issues related to how the clinic is functioning. And we know that this is not feasible for all teams and in all settings, but wondered if other people have had experience with virtual communication or other ways to have that cohesive care and discussions with your team.
I would like to listen to Judy. Judy has a really good experience in terms of digitalization of and communication between comprehensive healthcare teams using digital platforms. Judy, please share a little bit of
Yes,
your
thank
experience.
you. I just wrote that Stargate and SG2. It's very close, fantastic, and also very enthusiastic to think that we are together and sharing experience, opening gates between us. Yes, it's we are lucky because we had from more than 10 years the electronic record, and that helps us when we have virtual conversations and discussions to see the record of the patient and to take decisions that are for difficult cases online. And this is something that helps us. We start not very regularly, but from maybe 2 years, we are trying that every month. And it's a good experience because it makes shorter the way to take decisions when it's not very clear what should be done in some cases. So it's something that helps us, and thanks to the record that are already for open for everybody in the team, we can do it separately and not presently, but virtually. So it's a good experience.
Thank you, Judy.
Thank you. And I know that in some teams, they're not seeing their patients necessarily on the same day. And so when you have that communication that has to happen on separate days or when the patients are not present, that adds even more challenges. Anyone have any experience with that or recommendations for how to improve that kind of communication when you're not seeing your patients in one clinic day?
Yes, this is the experience that we have because we have a common meeting that not always everybody is present, but when we see there is a patient that is not very clear what to do, we are making a list of these patients and we set up an appointment, and then we can try to make something more clear for the patient also because it's written on the record. And so it helps very much because there are so many patients that it's difficult to remind every time when somebody calling, what do you think about this patient? Oh, I have to check. And then this helps very much, and it's a good experience.
Great.
I think there's a hand up, Savita.
Yeah. So what we generally do is we do have these fixed multidisciplinary clinic meeting days, which happens on a mutually convenient date to all the team members. So though this virtual meet might not facilitate synchronous meeting with the patients, but we can definitely do it in the asynchronous mode. So what we do is, so that it's during those meetings that we use the recordings of our patients or whatever data related to the patient is required, we bring it during those meeting days, clinic days, and we have the discussion. So synchronous meeting, either in physical space or digital space with the patient, is challenging, but to some extent, we can offset it by at least doing the asynchronous meeting and then taking decisions during those meetings.
Thank you.
I think Rupa raised her hand.
Yeah. Hi. Can I speak, Emily?
Sure.
Yeah. Thanks, Emily, and thanks for this presentation. I know it came through so much discussions that we had over the past few weeks. I did want to say two things. Two things stood out to me through all these discussions. One, of course, the need for meetings and communication was absolutely underlined by everybody. That was very interesting to me. The other thing that struck me, and we didn't pick this up, we didn't have an open-ended response to it. Despite, majority of our responses coming either from Latin America or from Africa, we didn't hear anything specific where somebody said, I find it very difficult to build a team because I just don't have, the orthodontist or the speech pathologist or, a specialist around. It was surprising because I think 5 or 8 years ago, that was the biggest team. How do I form a team without the specialist? So does that mean that, we have enough specialists in these areas now available, that we have so many teams that are being built up? It didn't, our responses didn't show that up at all. And so I was really relating to the other earlier discussion, whereon who are the key members of a CCC team. I thought maybe there are some takeaways from that. I think that was very important. And the other thing that was very interesting to me, is that not always, or there was quite an open thought process on who could be leaders of the team. And in many areas, it was the responses we got was, it's the social worker or the administrator or the speech pathologist or the psychologist were actually the binding features with, communicating with the, children or with the patients. And therefore, there's no real requirement of wondering who should be the team, but basically dependent on how the work goes, you choose a team leader. And I think the slide also demonstrated what the leader should be able to do in terms of interaction. That was quite interesting because traditionally the thought is, that the surgeon could be the leader of the team. So these were two things that to me struck out in all of the discussions we had.
Yeah. Thank you, Rupa. Hugh, you have your hand up.
Thanks, Emily, and thanks to the whole team. And if anyone else is struggling, if you click the React button, one of the options is raise hand. So if you're figuring out, how do I get my hand up there? That's how you do it. So the React button along the bottom, and then there's a selection for raise hand. I'm going to put Dr. Solomon on the spot, or anybody else who's a CCC team leader. I mean, Professor Rupa was just talking about leadership and how important that is. That came through in your recommendations in your survey. Dr. Solomon, how did you learn to lead a team? Is that something that you covered in medical school? Is that something that was, how do these skills of bringing in multidisciplinary approach and all that, how did you grow as a leader?
All right. Thank you very much, Hugh. I think you've taken my question and put it back to me, because I was going to put a question to the team, whether there's someone who have the experience and has built a team from scratch and is still leading a team to share their experience. And now you've turned it back to me. All right.
You can kick us off. We can hear from others though too. But yeah.
Yes. So we probably can hear from others, because I've seen Dr. Mekonnen, who is very much experienced. Started a team from scratch in Ethiopia, and has sustained a team. I've learned from him as well, because we collaborate in a lot of things. So probably he will share his experience, and then I'll follow up with that, if that is okay.
Thank you very much, Dr. Solomon. Thank you. You know, I was fortunate. I have not started from scratch. The team on a smaller scale started with the Norwegians. So the main thing we were able, myself with my friends, were able to sustain and to add what the Norwegians started. They have started it with a one speech therapist Norwegian and a surgeon, a plastic surgeon. Fortunately, they planned long, and they trained speech therapists, they trained surgeons, they involved ANT surgeon. And these were the professionals which were involved at the beginning. But later on, we included international NGOs like Transforming Cleft Now, Smile Train, and Project Terror. So with the support of specifically Transforming Cleft Now, we're able to sustain what the Norwegians started. So I have not started from scratch. I was lucky. It is the Norwegians who first showed us that really it's very important to work in a team, not surgery alone. So when they first started, they started as a team. So we learned from them, and I myself observed that really it is a team care which brings a change in the outcome of whatever we do. Not only surgery. I have myself witnessed. I have always mentioned this, that I met a girl who was dressed well, bone with cleft, operated, but were not able to speak properly because she didn't get speech therapy. But later on, when she gets speech therapy, speech surgery, after some years, I met her, and she was able to speak perfectly. So I learned a huge lesson in addition to what the Norwegians taught. I learned from my experience. So from that time on, I was really with my friends worked to sustain and to develop, add more professionals to the team we have. Currently, really, I would like to say thank you to Transforming Cleft at this time. Because of them, we have added many professionals, and now our team is the biggest. And we also learned a lot from Kumasi because we are really good friends, we collaborators. In fact, when the cleft care was transferred from the Norwegians to Transforming Cleft, we used the Ghanaian model. So we also learned a lot from you, Solomon. Thank you very much.
All right, thank you very much. So, like you said, I also did not start from scratch. I actually inherited it from my boss, Peter Donko, who started from scratch with a pediatrician, a speech pathologist, and a plastic surgeon. My boss is a maxillofacial surgeon. So that four of them came together to say that, well, instead of me seeing the patient, and then I refer the patient to the pediatrician to see, and the pediatrician finish and refer to the next, that kind of conveyor belt. Instead of continuing this, why don't we come together so that it will be a one-stop shop for the patient? So that is how our team started. When I joined in, I think what helped me is actually buy into the concepts and the ideologies of my predecessors. What the format they created, which was different from all the other centers in Africa, because most of the centers were outreach-based, but our center decided to put teams together and make it institutionally based, where when a child comes or a child is born with cleft everywhere in Ghana, everybody can say, go to this place, you receive care. And the care you receive is not just surgery, but comprehensive. So I bought into that idea and gradually learned from these pioneers, and based on that, been able to build our team to a very large group with other collaborations in Seattle and other places. So one other thing that has helped as it keeps on coming out from our discussions was good communication. We normally have times where outside clinic, we meet at dinner, we meet at places, casual, friendly environment where we can share ideas. One very example that actually brought our attention to leaders actually communicating well with team members. We went for one of our outreach programs where we were having surgeries, and the surgeon who was operating, there was this lady who was taking pictures for us. And it looks like the surgeon didn't speak well with the lady, so she was offended. Afterwards, when we were doing the review, the lady came out boldly to say that this particular surgeon said this and this to me, and I was hurt. And the surgeon humbly apologized. So I think that one thing that we learned from that is that when it comes to team building and sustainability of teams, the leader must not be autocratic or the boss. You must listen to everybody. And like we said in our recommendation, everybody's perspective is respected, no matter who the person is. Even if he's the one that is collecting data, he's so important. If he's the one cleaning the floor for you, he's so important. So everybody in the team is important and must have an equal say, which was one of the things, and it has been one of the things that I have been using, respecting every member in our team, and also trying to help others come up to take other positions or to take other tasks in the team. So this is what I want to share for now. If that is okay, maybe others can also share their experience.
Solomon,
Thank you.
thank you. I think also another thing that came up during our discussions was how usually it's the surgeon, the CCC leader, but if they want to spend less time with the patient. So I think any of our participants in our group would spend some time talking about that. And also at the same time, in some contexts, the surgeon, as a surgeon, has more authority to be the CCC team leader. And then some other professions, like maybe the speech therapist or the psychologist, for that reason, they are not really quite able to be the team leader because they don't have this attached authority because of their discipline that they had. So it would be great if anybody could comment on that. Olga.
Yeah. Yeah, Olga, you have your hand up. Thank you.
Hi, I'm speaking Spanish. Hola, ¿qué tal? Sí, yo trabajo en un equipo multidisciplinario que ya estaba establecido cuando llegué. Y a lo largo de los años he podido ver que el liderazgo lo lleva quien tiene la visión integral de las necesidades del paciente y su familia. No es tanto por la profesión o por el aporte que hagamos sobre el tratamiento, porque todos tenemos un momento, todos tenemos un objetivo, sino el que tiene la visión más integral. He tenido la oportunidad de trabajar de la mano con cirugía plástica, con trabajo social, con psicología, y he podido como aprender un poquito de esas áreas, no para entrar a tener opiniones muy relevantes, pero sí para poder identificar algunas necesidades y comprender un poco más este manejo integral y estas necesidades de los pacientes. Entonces, creo que el liderazgo más que una profesión específica es quien ha tenido más experiencia en cuanto a al seguimiento también de los pacientes a largo de su vida. Entonces, quería aportar eso. Muchas gracias.
Gracias, Olga. I'm not sure if everybody got a chance to hear interpret, but Olga is talking about her experience in her team, and she's talking about how the leadership, she had different leaders that she worked with, and wasn't attached to a special discipline. So it wasn't necessarily the surgeon or this or that, but it was more who had experience and had the vision about comprehensive cleft care, because who had that vision and knew how to execute the comprehensive cleft care with more skill about being a good leader for the team in that. Thanks. That's very nice, Olga.
Ruben?
Thank you so much. I just wanted to add to Olga's comments, which tied back to the recommendations and the need to have a leader and how that gels. It doesn't really matter. In hierarchical systems, traditionally hierarchical systems, yes, the surgeon has been the de facto leader. But we're seeing more and more that if you have other cadres of specialists, whichever one it might be, that has communication skills, strategic thinking, management experience, those people tend to play a key role in not only managing teams, but connecting teams to entire health systems. So to those of you who might be in a situation which say, I'm in psychology, so I'm not in a situation where I'm acknowledged as a potential leader. We have seen a shift in that and a very positive one. And I would just say to you, there is certainly definitely opportunity. It does take the ability to use your profession and certainly in psychology, you have that, the ability, again, going to management, communications, resource fundraising, resource allocation, strategy thinking, and those are things that really nourish or have seen nourish teams and have helped shift from the hierarchical, normal, usual structure in low middle income countries into one that is comprehensive and inclusive. Thanks.
Nico, your hand's up.
Thank you. Yes, so I wanted to like recap on the leadership on our experience. We started our team from scratch in Mexico, and there was no when we came there, we only had the space, and we started from there. One thing that I learned within our team is that leadership should be learned. Like myself, I had to take courses or like workshops on leadership, and I think very few importance of this sort of training is given within the core curriculum for providing cleft care. And I see that every provider is somehow a leader, because every provider in a comprehensive cleft care team has to identify barriers for their patients, has to identify means to overcome those barriers, has to design strategies where the provider should identify what sort of space I need, what sort of equipment I need, what sort of protocols should I implement, what sort of supplies are available, what sort of engage, what sort of strategy should I develop to engage with the primary healthcare level. So I think leadership should be given a place in terms of training, not only for that person that took the leadership of the center, but within the whole team. Every cleft care provider should be having some sort of training leadership and strategy leadership. In the other hand, I wanted to mention, like, I wanted to ask the people here, in terms, we listen a lot within the survey and the process about communication. Communication was very important within the surveys, and I wanted to ask, in terms of that communication for effective care, if any of you within your cleft teams made the shift from paper medical records to electronic medical records, and how that shift impacted the quality of care. I would like to hear from that, to understand how important is to, like, made an emphasis on investments on electronic medical records for comprehensive cleft care teams.
And while we're thinking about that question, and I'll get to some questions in a minute that are in the chat, Julieta has her hand up.
Julieta, ya puedes hablar.
Buen día, ¿cómo están? Quería comentar sobre la anterior discusión sobre los equipos multidisciplinarios, ¿no? Conformar equipos multidisciplinarios viene siendo muy complejo porque no es una suma de especialidades, es interactuar desde la multidisciplinariedad y con un carácter transdisciplinario. Entonces, llegar a ese objetivo final es bien complejo, ¿no? Tenemos que bajarnos de nuestros taburetes para ponernos sobre lo que es la necesidad del paciente. En este caso, por ejemplo, hablar sobre el liderazgo. ¿Quién lidera en una mesa de discusión? En una mesa redonda de discusión de casos, en un caso específico, dependerá mucho de la situación específica del tema a tratarse. Muchas veces puede ser que sea liderado por trabajo social, porque es el que conoce en el ámbito familiar de la familia, pero estamos hablando de qué momento específico estamos abordando en la discusión de casos de cada paciente. Y también es importante recalcar que lleva su tiempo conformar este equipo, ¿no? En Ainacuna tenemos una metodología horizontal, donde puede ser que estemos hablando de una discusión de un tema quirúrgico, entonces le compete al cirujano liderar esta mesa de trabajo. Si estamos hablando de un tema funcional, entonces ya será el fonoaudiólogo el que lidere la mesa de trabajo. Dependerá mucho de la necesidad del paciente y esto requiere pues de una horizontalidad, de una mentalidad trabajada en base a lo que es un equipo, ¿no? Hemos nosotros intentado digitalizar el sistema de información en la Inacuna Bolivia, pasar del papel a lo digital en cuanto a expedientes clínicos para contar con una estadística real en el tema de investigación, de impacto, de medición, de indicadores, que es tan importante, ¿no? Cuando uno quiere posesionarse. Viene siendo muy complejo porque el personal necesita entrenarse, capacitar, conocer, estar al día con la tecnología. Y esto también, así como conformar un equipo, lleva su tiempo, lleva una inversión de dinero, de tiempo y sobre todo de entrenamiento. No es tan fácil. Nosotros estamos en proceso, hemos desarrollado una base de datos a la medida en tema de FLAP para la fundación, pero llevarlo a la práctica de que eso sea funcional para todos, todavía estamos en camino. Es difícil, cada quien está en su rubro y ver la necesidad del otro viene a ser muy complejo, ¿no? Pero es necesario. No podemos hablar de una intervención a largo plazo y demostrar los resultados si no tenemos una buena base de datos, información clara, concreta y real sobre los resultados, no solo a nivel quirúrgico, no solo a nivel estético funcional, sino también a nivel emocional cuando se habla de equipos en atención integral. Y eso es mucho más difícil de medir porque es algo muy subjetivo, ¿no? Eso, muchas gracias.
Thank you. Those were some excellent points you raised. And there are also some questions in the chat from Krupa about how teams measure outcomes, how they measure their success working as teams, what outcomes you would look at in measuring your effectiveness as a multidisciplinary team. I wondered if anyone had any comments or follow-up to that.
I think Yuri raised his hand.
Yes, thank you for giving me this opportunity. I think that if we make too much control or critical remarks about our effectiveness, it will be also a problem. When we are, most of us volunteer, it's difficult if we make it this audit in a way to criticize that somebody is not doing his job. So it's difficult to make it really elegantly and in the same way to improve our effectiveness. This is my impression of my attempt to raise the attention of the serious way to control our work.
Thank you, Yuri. I think in terms of metrics to measure effectiveness of comprehensive healthcare team, it's really hard to measure when you have no records and the use of data becomes. I mean, we know that the use of data, and we have known that from forever. I would say that the use of data is very important for research, okay, clinical research or surgical research and so on. But nowadays that we're looking into patient-reported outcomes and patient satisfaction and quality of life as putting together all the efforts into the well-being of the patient, I think, again, the use of data collection and data management schemes or aids is so important. Like we've been working in Oaxaca over the last 5 years, yes, 5 to 6 years, we have provided care for over 750 patients, which it's not much if you look at the numbers of centers in Asia or like in other countries. And yet, by not having a really good electronic medical record scheme, it has been so difficult to measure the impact. So to me, I think it is important to go digital. It is important to go to electronic medical records, and it is important to measure the impact. It's important to understand how good are we in the delivery of care, and without data, we won't know.
Yes, Jory.
I'm sorry, maybe I didn't understand very well the question. In fact, we have included in our electronic medical record the data of the follow-up. So we are having some ages when we have to have evaluations. So when the patient is 16 years and over, we can measure the number of evaluation that we have for the patient. So it's a kind of measuring the quality of the follow-up. So this is already in our mind, and it's measuring the quality of the follow-up. But the collaboration and the quality of the work between our team, this is something that I was understanding in the past as a question. And this is more subjective, and it could create some individual problem. But measuring the quality of the follow-up is something very important in my opinion. And we include it in our electronic record to see how many. And for the start, because it's something very recent, we have different level of quality. If you have no record at all, it's completely not followed. If we have a group of patients that has only one data at 5 years, for example, it's a bad follow-up. But when you have 2 or 3 follow-ups in different ages in one specialty at least, we have medium follow-up, and we have good and excellent when you have most of the evaluation done in each year period. So this is our, for the moment, guidelines to measure the follow-up. And this is something that we would like to apply and to see, taking these metrics, to see if we can improve from now to 6 months later or 1 year later, our efforts to improve the follow-up.
Before you speak, Nico, I just want to let everybody know that we have about 10 more minutes, so it's a good opportunity to do the recap besides your contribution, Nico. We can't hear you, Nico.
I'm sorry. Yes, so I just wanted to make a final comment that I think in the previous meeting we were sharing with Ruben, and it's the importance of being when we provide care, we're clinicians. Most of us are clinicians. Most of us are trained in the provision of care. Most of us, some of us, will develop leadership skills in the way of developing comprehensive care solutions. But we need to I would invite the teams to look into how important are we taking the person who is the not the manager and the executive direction of a team, because that person, what I've seen is that the most successful comprehensive care teams that I have seen in the last 5 years are those teams, and the more sustainable teams are those teams where there is a very specific and strong member that is a manager, executive direction, that is orchestrating all the back office of the provision of care, where policy is taken care of, where I don't know, looking for resources is putting together, financial planning is putting together, because sustainability and capacity building demands that. And I think it's very often we take leadership into clinicians and we do not have those skills. So I think it's very important to discuss on that in the future of comprehensive care team building.
Thank you, Nico. Any final words, Emily or Salmon?
Rupa, you look like you
Yeah.
have your hand up. Yes.
Yes, so thank you all for this wonderful discussion. I just want to, reflect a little back on where we started in January when we started reading. Emily and Solomon had, put together some fantastic reading resources for us, and they're available on the, in the Circle of Cleft space. And what was interesting is, of the 3 or 4, major publications we read in detail, many of them were meta-analysis of meta-analysis leading to, multidisciplinary care. And I was surprised there were more than 1,000 publications in this area, not relating to cleft, but mainly healthcare. And there was just some fantastic ideas which resonated among our cleft teams. And I would really urge people to go back and, look at some of those publications, because they gave many of our recommendations, shine through that. That's some fantastic reading. And I hadn't understood actually that there was so many people had been actually documenting their work in developing multidisciplinary teams. So I really think there is some ways we have to go in the cleft world. And I think that, we should push forward in that area for sure.
Thank you, Rupa. Anyone else have any closing comments? I know Solomon's going to do a little bit of a recap.
All right. So thank you very much for coming. Just so yeah, let's see if we can go to the slide so that we just recap the teams that yes. So we, in addition to all the comments that we brought, I think there were a lot of also comments at the chat room that we were also looking at. We'll put everything together and see how best this recommendation can even be improved better. So at the end of the day, we have 5 recommendations. By the first one is creating the CC team, which requires meticulous planning, guaranteeing both sustainability and effective service delivery. So when you are building a team, maintaining the success is also very, very important. Our second recommendation was on leadership skills, which came out from this discussion that leadership is very important, and therefore some training and other things need. We also look at if effective multidisciplinary team care is built based on communication or effective communication and respecting the views of everybody in the team. And again, some of the challenges that LMIC's team building faces, we also look at that. And then we look at the resources that we need to actually sustain and build CLEF teams. So with these 5 teams, I believe we've been able to put everything together. If there are more, I think you can send to us, right, Elysis? And we can add to what we have. Thank you very much for coming and making this meeting a success. Back to you, Elysis.
Yes, thank you so much for joining us and discussing this very interesting topic and that applies to any team. I just want to thank our co-chairs, Emily and Solomon, who guide us through this process, and also all the participants from an SG2, and also our presenters today, Carolina, Isan, and Nico, for your help today. Just wanted to remind everybody then that what's next, it's the closing plenary. So you have about 5 minutes, but then what you have to do to find your space, it's go back to the circle where it says enter the conference and head to S4CCC closing plenary, and that will take you to the Zoom link. And that would be, I believe, everything from us.
Thank you, everyone.
Thank you, everyone.
Thank you very much.
Thank you.
Thank you.
Thank you.